Hi, good morning, everyone. Um, I'm Dr. Priyanka, and today we are going to um, learn about the topic diagnosis and treatment planning in fixed. Okay, so the learning outcomes are as follows. Um, the first one is describe the sequence of recording extraoral and intraoral findings, diagnostic indices for partially edentulous and for completely dentate patient basis on diagnostic findings, so which has specific diagnostic criteria, location and extent of edentulous area, condition of abutment teeth, occlusal scheme, and residual ridge. Okay, and then coming to the last outcome is general and local factors and influence the patient's prognosis. Okay, so coming to the general or the clinical examination, so we have to, when the patients come to you first, we start with the history of the patient. We have covered history in many other seminars before, so I'm not taking it up here again. I'm not repeating myself, guys. Um, we'll be discussing that in the um, face-to-face time. Yeah. So, so starting with the history first. So, any systemic history has to be taken and has to be known the importance of which. Okay. And now coming to the clinical general examination. So, um, extraoral examination is first. So, you do check the head and neck examination, you do it, you palpate. The muscles of mastication, you also palpate the TMJ, and you see the movement of the TMJ. Okay, so any abnormalities in this has to be recorded. Okay, coming to the intraoral examination, oral hygiene status is extremely important in our fixed prosthesis, as we have discussed in the last class, and we'll keep discussing this. This has to be taken care of, and we have to know that the periodontium and the gingiva is fine to proceed further with the treatment. Yeah, nature and quantity of saliva is also important. It will define the nature of the treatment which we are going to do. Yeah, and will also help in determining how do we manage the case. Okay, examination of the teeth obviously is very important. This is the main thing that we are doing. So basically, we are going to, as discussed in the last class, we are going to see the status of the periodontium and the abutment teeth. Yes, and the occlusion. Yeah, coming to the occlusal examination. So the occlusion is main here, which has to be taken care of and has to be examined. Okay, and then the periodontal examination. So it will always be these things, and it will be always in this order. Okay. Okay, coming to the radiographic evaluation, example here is an OPG, everyone knows that. Yeah, so you can take any type of x-rays you want. Either you take like 14 IOPAs and 4 bite wings, which obviously we don't do, we stick to a panoramic radiograph. Yeah, we take an OPG. Yeah, if you see any deviation or movements in the TMJ which are abnormal, then you do take the TMJ radiographs, only if required. All of them give some examination of the findings that cannot be clinically detected, right? You have to see it radiographically. So coming to the radiographic evaluation, yep, example here of one of the cases. Okay, so remaining bone support and bone quality has to be assessed, um, and you have to see any remnants of any root pieces, any periapical pathologies, anything associated here. Okay, root number and morphology, yes, it has to be seen. If it's root canal treated, not treated, how's the pulp chamber? Is it too high up or is it at the normal level? Because we are doing a tooth preparation, guys. Yeah, periodontal ligament and any signs of TFOs has to be taken care of and checked properly, because abutment teeth are very important. The periodontium has to be perfectly all right. Yeah, resorption or furcation involvement, yes, guys, if there's a furcation involvement here, then probably it's going to go, the treatment is going to fail, right? And probably the teeth is mobile, so we're not going to do a tooth preparation in such cases. Carious lesions, again, everyone knows, if there are deep caries and it proceeds further, if there's any periapical pathologies, has to be taken care of. RC has to be done. The lesion has to be resorbed before you take the teeth as abutments. Okay, Pulpal status has to be taken care of. The height of the pulp can be seen clearly in the radiograph. Um, Again, periapical pathologies, like I just said, has to be taken care of. Routine roots, calcification, foreign bodies has to be taken care of, guys. We don't want to place a bridge and then see that some root stump is coming out or bony spicule is coming out from the pontic area, right? Yeah. Or manifestation of systemic diseases. Again, in the history, yes, very importantly, has to be taken care of and recorded. Coming to diagnostic impressions and cast, yeah, so we do take diagnostic impressions, guys. Yes. If we do, so this diagnostic impression exactly is not for FBD, guys, but it's just example of diagnostic impressions which are here. So diagnostic impressions can be taken by alginate in a stock tray. It has to have no void and has to be poured properly. Type 3 dental stone has been used. There has to be a proper base. You have to pour a base, and there has to be a proper land area, and it has to be all trimmed out well, and it has to look exactly like this. Yeah, it's for the diagnosis. Okay, so here, if we are doing FBD on one of the quadrants, guys, right? So we have just taken a bite like we do on an occlusal rim, yeah, on a U-shaped rim, like we do take in an FBD case, and we have just mounted it arbitrarily on an articulator. Yes, this is a Hana articulator, guys. We do not use this for you guys. So just to see how much space is there and just to do a mock wax up, right? It can be used for studying, it can be used to show the patient, yes? So diagnostic cards provide valuable preliminary information, comprehensive overview of a patient's needs. Treatment procedures can be rehearsed on the stone cast before making any irreversible changes in the patient's mouth. Used for diagnosis, diagnostic wax-ups, prelim RPD design, surgical stents to explain the intended procedure to the patient. So all of this, I mean, I don't think I need to explain this, right? Okay. Diagnostic wax-up must be completed prior to the beginning of any reconstructive treatment, that is casting, prosthesis, definitive periodontal therapy. So if it's complete, you can show the patient. So there, we have done a diagnostic wax-up. I'm probably giving in an FPD on the maxillary quadrant. I'm giving in an RPD here, a CPD here. So you can just see and show the patient that this is how it's going to look like, this is how it's going to function. So it's for clinicians and the patient's better understanding. If you really have to do it, you do it. So usually we do it in complex cases, not in everyday day-to-day cases, but this is something you should know. Okay, so the usefulness of diagnostic wax-up is it shows the proposed treatment to the patient, used for fabrication of provisional restoration, fabrication of final restoration against the diagnostically waxed cast, allows establishing an optimum contour and occlusion. So we have to see the contour and occlusion maybe in some malaligned cases, or patients who are maybe looking for smile designing, in FMR cases, which is full mouth rehabilitation. So it has to be taken care of. Okay, provide specific information about desired root length and form or occlusal arrangement. So again, it's a very good way to communicate between the dentist and lab technicians, right? Okay. Now coming to the general and the local factors, like stated in the learning outcomes, guys. Okay, so factors which are general consist of systemic problems. Any systemic problems, the main ones here comes in a diabetic patient, which are more prone to periodontal diseases, and they also have slow healing, right? So that's just an example. History and success of previous dental treatments is very important, guys. So any failed treatments, any previously treated prepared teeth, and if the patient comes again for the treatment of the same teeth, what has to be done? So history and previous dental treatments are also important, if any are present, right? Local factors again is almost some things we have covered in the previous slides, that is vertical overlap of the anterior teeth, the overjet overbite of the teeth, impactions if present. You're placing um, yeah, so I do have a case like that. I'm still waiting for the patient to come back. Uh, the patient earlier had a bridge on 3.5 to 3.7 region, and she had an impaction issue with 3.8, and she came to consultation with me, asking for why there's a pain, in the bridge. I didn't do it, guys. It was done before, and we took an x-ray and we discussed with the perio and the surgery department. We found out that there's an impaction. It's very close to the mandibular canal. So we referred her to GH and the hospital to get it extracted. So I actually had to cut and remove the crown, the bridge, and I place single crowns on the abutment, a temporary crown, so that the surgeon can operate. And then I'm still waiting for her to heal and come back. So such things happen. If that impaction would have been taken care of before, earlier, that problem wouldn't have been arised. Okay, so tooth mobility is a major issue. Abutments have to be very critically evaluated, right? Root angulation sometimes are a problem, so it has to be evaluated in the x-rays like we discussed earlier. Root structures, crown root ratios has to be evaluated, guys. Okay. Okay, coming to the diagnosis and the prognosis. Dental and medical history is very important, guys. Like we just discussed, clinical examination, diagnostic pictures, diagnostic cast, diagnostic wax-up, radiographic films, all consist of parts which make up our final diagnosis. Okay, prognosis is the general and the local factors, which are the age or environment, etc. All the general factors and all the local factors, occlusion and the oral hygiene and etc. comes under prognosis. Comes under making the prognosis of a. Okay, developing and treatment options factor to be considered, guys, is the patient expectations, systemic and emotional health, cost, periodontal factors, success rate, possible complications has to be told to the patient on day one, guys. Yeah, and if possible, take a signature. Otherwise, you might be in trouble. Yeah. So time involved, number of visits. I tell you every time when the patients comes, the number of time the patient has to come, the total cost, and the time for each appointment has to be explained, and the prognosis of the treatment has to be explained that date, then and there. Yeah, which will help the patient and the doctor do the treatment, right? Influence on quality of life. How's it going to actually help the patient? So everything has to be evaluated, and then you can derive the treatment plan, whatever for the whatever type of treatment you're doing, can be calculated, right? Okay, coming to, I'm not going in the phases of the treatment plan, you all know that. Yeah. Okay. uh, Prosthodontic Diagnostic Index. So this is the index we were talking about in the learning outcome. That's the only index, that is the PDI. So according to ACP, that is the American College of Prosthodontics, they have developed this diagnostic index for partially edentulism and for completely dentate patient on the basis of diagnostic findings that are summarized here. So we'll be summarizing all this. These guidelines are intended to help the practitioner determine appropriate treatment for their patients. Okay, so basically we do have four factors, and we are divided those four factors into four classes. Okay, guys, so we will look it up. First, we're just going to talk about the factors, and then we'll be grouping them into four classes. Okay. Class 1 to Class 4. So Class 1 represents the uncomplicated clinical situation. Class 4 represents the complex clinical situation. Okay, each class is differentiated into specific diagnostic criteria as stated in your learning outcome, right? So specific diagnostic criteria is ideal or minimal, moderately compromised, substantially compromised, severely compromised. This is class 1, 2, 3, and 4, right? And there are four factors: location, extent of the edentulous area, condition of the abutment teeth, occlusal scheme, and the residual ridge. Okay? Yeah. So coming to a worksheet which is given in our Rosenstiel, the book, it's used to determine the PDI classification. So this is just an example, guys. So you can see The whites are all the class ones, right? So in class one, you'll get this. You'll get an ideal and minimally compromised single arch. You will get an ideally or minimal compromised abutment teeth. Occlusion will be ideal, and it'll be a class one edentulous ridge. Okay. Similarly, class 2 and class 3, class 4. Okay, we'll be discussing it in detail. Okay, worksheet again, it's almost the same thing, guys. Yeah, so they're just marking it how it is in another way. Same thing, guys. Okay, coming to the first one is the location and extent of edentulous area or areas. So here, to keep, you have to keep in mind that either the ridge is ideal, moderately compromised, substantially compromised, or severely compromised. So now in an ideal ridge, it will be confined to single arch. Yeah, it will not exceed more than 2 missing teeth for the maxillary, and for the mandibular, it will not extend more than 4 missing incisors. Okay. Any posterior maxillary mandibular span that does not exceed 2 premolars or 1 molar. Okay. So any of this condition will come into ideal or minimally compromised edentulous area. Okay. In moderately compromised edentulous area, the edentulous span is in both arches. Yeah. So the span includes any anterior maxillary span that does not exceed 2 missing incisors. Okay. Does not exceed 4 missing incisors. Here it does not exceed. Here also it does not exceed. Okay. Here it comes to same, does not exceed 2 premolars or 1 premolar or 1 molar, right? Does not exceed, guys. A new criteria here is maxillary mandibular canine is also missing, okay? And this is both arches, guys. Coming to substantially compromised ridge, 3 missing teeth or 2 molars, 3 or more missing teeth, okay? Severely, it's a combination of edentulous. Okay, coming to abutment. So now you get it. I'm going to divide it into 4 divisions again. Abutment here, in an ideal case, no pre-prosthetic therapy is required. In a compromised case, there's localized adjunctive therapy which is required, which is one of these. In substantially compromised abutment teeth, extensive adjunctive therapy is required. Severely compromised abutments have guarded prognosis, guys. Yeah. Okay. Um, so coming to the occlusal scheme, which is the third one, in a minimally compromised case, no prosthetic surgery is required on any of the occlusal areas, and it's a class 1 molar relationship. Okay. In moderate, you might get some enameloplasty or premature contacts. In substantially compromised scheme, you might get entire occlusal scheme required for reestablishment. Severe compromise occlusal scheme, you might get some changes in the occlusal vertical dimension. Okay. Yeah, and it can be a class 2. Coming to residual ridges, so now we are going to classify into class 1, class 2, class 3, and class 4. Okay, so here this classification system for completely edentulism are used to categorize edentulous span, okay, present in partially edentulous patients. So classification system has divided itself into 4 types. Okay, so that's class 1, class 2, and class 3. In class 1, it is characterized by ideal or minimally compromised in the location and extent of edentulous area, abutment, condition, and occlusal characteristic, and residual ridge. So you see all the 4 criteria lie into an ideal state or minimally compromised state. So the location is single arch. It doesn't, the abutment doesn't have any need of pre-prosthetic therapy. The occlusal scheme is class 1. Residual ridge resorption, morphology is class 1 also. Okay. Guys, so there are two clinical photos which associated with class 1. You can see that it is just one space, yeah, which is edentulous, right? And we are going to give a 3-unit bridge here. You see the occlusal relationship, the extent of the ridge, the location, the abutment, everything looks fine. Yeah, I don't see any caries, any periodontal issues. Everything has been taken care of. So this is a more or less an ideal situation. Same thing here, guys. Exactly same thing here. Yeah, it's a class 1 case. It's ideal or minimally compromised. So it's actually an ideal case. Yeah. And we are looking for replacement of to place a crown on the RC treated teeth. Yeah. Coming to class 2, so here there will be moderately compromised location or extent of the edentulous area in both arches. Abutment conditions will be having a localized adjunctive therapy. Occlusal scheme may necessitate localized adjunctive therapy and residual ridge conditions, right? So both arches will be compromised here. For the abutment, there will be one or two sextants have insufficient tooth structure or intracoronal support. Abutment in one or two sextant require localized adjunctive therapy. Occlusion is class 1, but it may require some enameloplasty or hyperine reduction. Residual ridge structure will be class 2. Okay. So guys, you can see that two sextants are involved, right? That's the maxillary, this is the mandibular, yes. And the teeth might require some therapy. Yeah, the abutments, guys. Yeah, that's why we have taken an UPA for the same. Yeah, so this is a class 2 case. Same here, guys. Yeah, so now we are actually we only wanted to replace 1, 2, 3, and 4 places with crown. It's involved for both the arches, and there are some therapies which are done for both the arches. Yeah, some adjunctive therapy has been done. So this is a class 2 case. Okay, coming to class 3, guys. It is characterized by substantially compromised location and extent of edentulous areas in both arches. Abutment condition necessitates substantially localized adjunctive therapy. Occlusal characteristic necessitate any reestablishment of occlusion without any changes in the occlusal vertical dimension. Okay, so both arches again are involved. The condition of the abutments are abutments in 3 sextants have insufficient tooth structure. Localized adjunctive therapy again is needed. They do have fair prognosis. Occlusion is compromised, but they're without any changes for occlusal vertical dimension. Relationship is class 2 molar relationship, the occlusal relationship, and finally the residual ridge is class 3. So yeah, sorry guys, yeah. So now you can see that it has been treated. Um, RC has been done, guys. Some crowns have been placed. The radiograph, the OPG is not clear, so maybe you need to take radiographs or specific teeth, and mostly all of the sextants are involved. There are adjunctive therapy done in all of them. So this is coming to a class 3 case, and the occlusion is not totally fine. There are a little bit resorption as well, attrition as well. So the video has not changed, but still a class 3. Okay, coming to class 4, which is characterized by severely compromised location, extent of the edentulous ridge with areas with guarded prognosis, abutment requiring extensive therapy. Occlusion characteristic requires re-establishment of occlusion with changes of occlusal vertical dimension and residual ridge condition. So both the arches are involved. There has to be some congenital or acquired defect. Prognosis is guided. Abutments are everywhere. They're also compromised. There's localized adjunctive therapy which is required. Occlusion is severely compromised, can be class 2 div 2 or class 3 molar relationship. Residual ridge structure confines to class 4. Yeah, so you can see that severe atresia has been taking place. There is changes in the vertical dimension at occlusion. There has to be a lot of things which has to be taken care of. There's no place for a replacement. So either you have to do intentional RCT for those. If there's already treated, then we have to see what has to be done for the lower. All the arches are involved, basically, guys. It's a very compromised. Yeah. Coming to the last slide, guys. Here, this is a classic case of a full mouth rehab case. Severe atresia has been there in the upper and the lower ridge, and there are missing teeth here and there, and there is impactions, there are fillings, there's you can see roots are visible. It has to go for a full mouth rehab. Yeah. It's a severely compromised case, and a lot of therapies has to be done so that we can actually restore and give like full mouth crowns or bridges. That is known as an FMR case. So this is class 4, guys. Okay. So hope you have understood all those things, guys. References stays the same. These are the standard textbooks for FPD: Schillenberg, Tillman, and Rosenstiel. So do refer to the book, and this seminar is basically most of Rosenstiel. So you read the seminar. If any questions are there, I'm always on level 20, guys, Polyclinic 3 in Prosto department. Come and see me, and we'll do more discussions in the online session.